saying that I would ask that you listen very carefully and decide whether the headline should be "may omit" or "may one day be able to omit," because as much as we as investigators like to have really press-worthy, ready for application studies, I think we need to walk with a little bit of caution here. So I'll be speaking about the 5-year outcomes of the IDEA trial of endocrine therapy with without radiotherapy after breast-conserving surgery for postmenopausal women who are aged 50 to 69 and have genomically selected favorable stage 1 breast cancer, on behalf of the IDEA trialists who are listed below. And those are my conflicts. So, as background, radiation therapy is standardly recommended after lumpectomy surgery as part of breast-conserving therapy because numerous randomized trials, the highest level of evidence in medicine, have demonstrated that radiotherapy improves local control of invasive breast cancer, and meta-analysis, the even higher standard of evidence in medicine, demonstrates that the reduction in recurrence that's afforded by radiation treatment also provides a modest overall mortality benefit, a survival benefit. So radiation treatment is incredibly important in the process of breast conservation to avoid mastectomy, but not all subgroups of women attain the same absolute benefit from radiation treatment. And the survival benefit appears specifically to be restricted to women who have a larger absolute reduction in their recurrence risk from radiotherapy. Now, there have been a number of trials in older postmenopausal women, women aged 65 to 70 and older, that have suggested that some women with hormone receptor positive early stage breast cancer can safely omit radiation treatment as long as they're willing to accept a somewhat higher risk of breast cancer returning in the breast. 9 to 10% at 10 years if they don't get radiation, 1 to 2% if they do. And you can think about this, if this were someone that you know, 9 to 10% might be acceptable to some women who are 65 or 70 and older. For others, they'll want to have radiation treatment and receive 1 to 2%. And that really depends on a lot of things: the burden, the side effects of radiation treatment, their own values, their own preferences. We know right now, ready for prime time, we absolutely can offer omission of radiation to older postmenopausal women. But the question remains, can we one day offer this to younger postmenopausal women, at least some younger postmenopausal women? And so that's what motivated this study, because we know that there are a number of genomic tests that are currently in use, including a very commonly used 21 gene assay that's used to make decisions about chemotherapy and that might have some utility in the context of deciding about radiation treatment as well. And so this is the design of the study. So this is what we call a prospective, single-arm, multi-center cohort trial. What it means is 200 women were enrolled, all of whom had age 50 to 69, one focus, unicentric invasive breast cancer. They all underwent lumpectomy, which had what we call a negative margin width, a rim of normal tissue around the tumor of at least 2 millimeters. And they had hormone receptor disease that was ER and PR positive and negative for HER2. It was not spread to the lymph nodes. It was 2 centimeters or less in size. And this 21 gene recurrence score was less than or equal to 18. And all of these 200 women were treated uniformly with the omission of radiation treatment and at least 5 years of what we call endocrine therapy, which is kind of like anti-hormone therapy. We call it hormone therapy. It sounds too much like hormone replacement therapy. Endocrine therapy for at least 5 years. Okay, so that was the plan. 10 years of surveillance on study with the primary analysis to be conducted at 5 years, which is what I'm presenting today. The mean age of our patients was 62. The median follow-up, 5.2 years. And here is the nutshell version of the main results, okay? Overall in breast cancer-specific survival, 100%. Freedom from any recurrence, 99%. Those are some pretty good, promising numbers there, right, folks? Those are 5-year numbers, okay? So here it is in a different format. What you can see is that we had 2 recurrences that occurred by 5 years, which is the time point for analysis in this study. But we also had 6 patients who recurred later than 5 years. And you can't make anything of the curves over their past 5 years, because if you look at the bottom, there are very, very few patients who've reached that point. So we have no certainty about the estimates after 5 years. But what I am saying is that even though these are really promising results, showing that this might well be a really good idea, at 5 years, women who are younger postmenopausal women, aged 50 to 69, need more follow-up before we change the standard of care practice for these patients. It's reassuring there were no distant recurrences, and the crude rates of overall recurrence were reassuringly low, both in the women who were in the younger subset we enrolled and in the somewhat older, younger subset we enrolled. To place this study into context, there have been a number of other single-arm studies and randomized trials that have been initiated. The Lumina trial was reported just a few months ago, earlier this year. Precision and Primetime have yet to report. And then these randomized trials over to the right-hand side of the screen are ongoing in other parts of the world, and Deborah here in the United States. And in particular, and I know this isn't the most sexy, press-worthy takeaway of this, the takeaway of this is actually, if there is a younger postmenopausal woman who meets the criteria for inclusion in IDEA, what we really should be doing is encouraging them to enroll on Deborah, which is a randomized trial of this approach, and will actually collect quality of life information to let us look at questions like whether women are more worried about recurrence of their breast cancer if they don't get radiation treatment, or if they feel like they need to persist with their endocrine therapy despite really intolerable side effects because they're not getting their radiation therapy, and this is all that they're relying on for their control. So ongoing research is absolutely essential. So in conclusion, very low 5-year risk of recurrence using a genomic assay in combination with classic clinical and biologic features for treatment selection, including postmenopausal women under the age of 60, which really is novel about this. I want you to think this is press-worthy, but I don't want to go too far. We need long-term follow-up of this trial and others to determine whether the option of avoiding initial radiotherapy can offer to a broader group of women than current guidelines recommend. And what's really important here is that we're trying to empower patients with choices, return to them a sense of agency that, of course, can be so deeply meaningful. We have to also note that there have been advances in radiation treatment that have substantially reduced toxicity and burden of treatment. Patients who were eligible for this study are also candidates for regimens treating the whole breast or part of the breast. Most of these women could receive 5 fractions or fewer of radiation treatment. That's 5 treatments or less. And it is extremely well tolerated. So what I don't want is for the headline to read, brutal or harsh toxic effects of radiation can finally now be avoided, because I don't want us to scare off, first of all, the patients who clearly do need radiation, or really anyone, because what we want is rational deliberation about treatment options for patients. We have a responsibility here. So please, and every investigator wants their work to have an impact. I want mine to have the right impact. I want this work to offer more choices to patients, many of whom will actually say, I want radiation treatment. And that's fine, and especially right now for the younger postmenopausal women, the implication here is it is absolutely a great idea to enroll on the larger randomized trials that are ongoing in this space so we can ultimately have really robust long-term evidence to inform the choices of our patients. So this is the Deborah trial again. That's actually the Monday morning practice implication, is that there is an ongoing trial that these patients should be offered. I really want to thank our funders, particularly the Susan G. Komen Foundation, and our institutions, as well as our colleagues and, of course, our patients, and all of you for your attention. I'll take any questions.